Hi everyone, so welcome back. Now we are going to discuss about metabolic acidosis. We are familiar with this diagram about determining the primary disorder. So basically when the pH is less than 7.35, we would call it acidemia, and because the mechanism behind this was decrease in bicarb, and that's why it's going to be metabolic acidosis. Metabolic acidosis can be divided into three different parts. First is high anion gap metabolic acidosis, second is normal anion gap metabolic acidosis, and third is low or negative anion gap metabolic acidosis. When we talk about high anion gap metabolic acidosis, we need to understand two other concepts, delta delta and osmolar gap. We are going to tackle this later. When we talk about normal anion gap metabolic acidosis, these three concepts about urine ammonium clearance, urine osmolar gap, and urine anion gap are going to help us understand the causes of metabolic acidosis, normal anion gap metabolic acidosis. So urine anion gap. What is urine anion gap? As the name suggests, it is the difference between urine cations, which is majorly sodium and potassium, and chloride. Remember that in case of plasma anion gap, we also had bicarb, which we don't use here as the quantity of bicarb is very low in urine. Now, I cannot overemphasize this statement. Kidneys excrete acid in form of ammonium ion. Kidneys excrete acid in form of ammonium ion, and this is specifically distal acidification, which means distal part of the nephron. If we remember this, everything is going to be easy to understand. And another pearl is that ammonium ion is excreted mostly in form of ammonium chloride. So what happens if we put this and the urine anion gap together? Then we realize that whenever there is an increase in ammonium secretion, there's going to be an increase in chloride secretion, and that's because ammonium is secreted in form of ammonium chloride, and whenever there is increase in chloride, it's going to decrease the urine anion gap. So increase in ammonium secretion is going to lead to decrease in urine anion gap. And what is the normal value of anion gap? It is 20 to 90. The second thing is urine osmolarity. So the formula for urine osmolarity is 2 times sodium plus potassium plus BUN upon 2.8 plus glucose upon 18. And why do we use sodium, potassium, BUN, and glucose? Because these are the major solutes that contribute to the osmolarity, and that's why it's a part of the calculated osmolarity. But we can also measure the osmolarity, right? And when we measure the osmolarity, this is going to also measure other solutes which contribute to the osmolarity. So in addition to this, it's also going to take into consideration other solutes, and that's why this difference between measured osmolarity and calculated osmolarity is called the osmolar gap. Now when we talk about these solutes, whenever there is an increase in ammonium secretion, this solute, ammonium ion in this solute, becomes significant, and that's why whenever there is increase in ammonium ion, there's going to be increase in measured osmolarity, because remember, this ammonium is a part of the solute that is considered in the measured osmolarity. And as a result, because measured osmolarity is increasing and we use the formula for osmolar gap, then that means that urine osmolar gap is going to increase. The normal value of urine osmolar gap is between 10 and 100. This is just a kind of recap that we already talked about. So again, the same thing, kidneys excrete acid in form of ammonium ion. So measuring ammonium ion is the most accurate method of further classifying non-anion gap metabolic acidosis, but we seldom measure it, and that's why we use urine osmolar gap and urine anion gap as a proxy. urine osmolar gap is a better proxy as compared to urine anion gap, as urine anion gap cannot be reliable when the pH is more than 6.5, there is polyuria, and urine sodium is less than 20. And as we discussed, if there is increase in ammonium clearance, the urine osmolar gap is going to increase, and whenever there is increase in again ammonium clearance, the urine anion gap is going to decrease. So we also need to remember for further discussion. Let's talk about the causes of non-anion gap metabolic acidosis. The causes can be divided into three broad categories. The first one being loss of base via gut, then loss of base via kidneys, and gain of mineral acid. So whenever there is loss of base via gut, what the kidneys are going to do is it's going to try and excrete acid, and this acid is excreted via distal acidification in form of increased ammonium ion secretion. Same thing. I'm just repeating the same thing again and again just because it's easier to understand. And as a result, the urine anion gap is going to fall and it's going to become negative. Remember, the normal urine anion gap was between 20 to 90, but it is decreasing over here, and urine osmolar gap is going to increase, and this value, when it's more than 400, it tells us something. And if we remember, the normal osmolar gap was between 10 to 100, so this is definitely increased. And whenever we are talking about this, in this particular situation, this is mainly because of GI conditions, because remember, we are talking about loss of base via gut. This can be in form of diarrhea, urethral diversion, biliary and pancreatic fistulas, and this is a condition that is a subsection of this, because the mechanism is same as the mechanism in gut, because although kidneys are involved, but distal acidification is intact, and the various causes could be type 2 RTAs, there are some meds, and late toluene ingestion. So again, although kidneys are involved, but distal acidification is intact, that's why I'm putting it and discussing it under this category. The second thing is loss of base via kidneys. When there is loss of base via kidneys, that means technically the kidneys are not able to do its job. So kidneys are not able to do distal acidification, which means they will not be able to excrete acid by increasing ammonium ion, and when this does not happen, urine anion gap and urine osmolar gap are going to remain pretty much within the normal range. And this happens in early uremic acidosis, type 1 RTA, type 4 RTA. And there are different causes for type 1 RTA, like mainly like drugs like amphotericin, lithium, and Sjogren syndrome, and type 4 RTA, which could be hypoaldosteronism or pseudo-hypoaldosteronism. The third cause could be gain of mineral acid. So we can see this in fluid resuscitation with saline or HCl or NH4Cl administration, and also hyperalimentation. This is a mnemonic by which we can remember the various causes of non-anion gap metabolic acidosis. H stands for hyperchloremia, another H stands for hyperalimentation, then Addison disease, renal tubular acidosis, diarrhea, acidozolamide, spironolactone, and saline infusion. And we are briefly going to touch upon this topic of load or negative anion gap metabolic acidosis. So hyperchloremia caused by high levels of certain cations like lithium toxicity, monoclonal IgG gammopathy, and some disorders characterized by high calcium or magnesium is going to lead to low or negative anion gap metabolic acidosis, and this is also going to be the case in pseudo hyperchloremia in case of bromide and or iodide intoxication. That's it for now. Thank you, and please leave your questions and feedback in the comments section below.